Hi guys, welcome to Radiology 365, where we try to cover core radiology from cover to cover. Still on our discussion on the mediastinum, today we're going to be talking about middle mediastinal masses. So the first one we'll talk about is adenopathy, enlarged lymph nodes. Now, lymphadenopathy is an important cause of a middle mediastinal mass seen on radiography. The etiologies include malignant and non-malignant causes, lymph node calcification, low attenuation, and avid enhancement of the lymph nodes are unusual features for lymphoma. So an alternative diagnosis should be considered anytime these imaging findings are seen. When you have eggshell calcifications of lymph nodes, you should think silicosis and co-workers pneumoconiosis, less commonly sarcoidosis, but because sarcoidosis has a greater prevalence than silicosis and co-workers pneumoconiosis, you would commonly see sarcoid with eggshell calcifications overall. Then when you have low attenuation of the lymph nodes, it's a non-specific finding, but it should raise concern for active TB. Sometimes low attenuation of the lymph nodes can also be seen in fungal infections like histoplasmosis, lymphoma, and some metastatic diseases. When you have hemorrhagic high attenuation within the lymph nodes, it can be seen in anthrax inhalation as part of hemorrhagic lymphadenitis and mediastinitis. Then when you have avid lymph node enhancement, it's seen usually in Castleman disease. Also, sarcoidosis, TB, and vascular Mets have avid lymph node enhancement. Some of the avidly enhancing metastases include renal cell carcinoma, thyroid carcinoma, lung carcinoma, melanoma, among others. We mentioned Castleman disease as one of the causes of avid enhancement. Now, Castleman disease is also known as angiofollicular lymph node hyperplasia. And as we see, there's angio in there, meaning blood vessels. So it makes sense that it will be avidly enhancing. It's a cause of highly vascular thoracic lymph node enlargement, and the key imaging feature is avidly enhancing lymph nodes. We can have unicentric Castleman, and that is seen as a single enlarged lymph node in children or young adults, and surgical resection is usually curative. And then we also have multicentric Castleman disease, and this is almost always seen in patients with AIDS associated with human herpes virus 8. Multicentric Castleman disease usually results in systemic illness. So you would have fever, anemia, and sometimes lymphoma as well. Because of its systemic nature, it's typically treated with chemotherapy and not just excision like in the unicentric kind. Next, we'll talk about epicardial fat pad as a mass seen on radiograph. A prominent epicardial fat pad would silhouette the cardiac border on frontal radiographs, and it may simulate cardiomegaly. So in this image, we see this radiograph showing a hazy opacity overlying the left heart border here, and the axial CT shows fat stranding and edema of the left epicardial fat pad as seen here, and this fat stranding and edema is in keeping with an infarct. So this is an infarcted epicardiac fat pad. It could present with symptoms that mimic myocardial infarction. Next, we'll talk about pericardial cysts. A pericardial cyst is a benign cystic lesion thought to be congenital and associated with the pericardium. Most of them are located at the right cardiophrenic angle between the heart and the diaphragm. And on imaging, you would see a cystic lesion abutting the pericardium, which may change in shape on subsequent studies. So this frontal radiograph shows this mass at the cardiophrenic angle. It's silhouetting the right heart border. This is a different patient. This axial CT is a different patient, but with the same pathology. And we see this cystic lesion abutting the right heart border. And this was proven to be pericardial cysts. Then cardiac masses can also show as mediastinal lesions, especially seen on CT and on plain radiograph. Cardiac masses can be intracavitary, can be valvular, can be intramural, or epicardial or pericardial. And the composition of the mass, its behavior at the margins, and the way it enhances are important diagnostic imaging features, as we will see later when we get into the cardiac chapter. Now let's talk about thoracic aortic aneurysms. I'm just mentioning them. We are not going to go into detail, but let's just know at the back of our mind that they are also a cause of mass-like lesions in the mediastinum, especially seen on plain radiographs. These are an abnormality of the ascending aorta or the aortic arch, or even the descending aorta, and they would appear as a mediastinal mass on radiographs. So this image shows a markedly dilated thoracic aorta involving the arch and the descending aorta. And as you can see, it looks like there's this huge mass sitting in the mediastinum. Then another thing to consider is an enlarged pulmonary artery. This can simulate a mass on chest radiograph, as we've discussed previously when we're talking about pulmonary hypertension. Then we also mentioned that the hilum convergence sign can help distinguish between an enlarged pulmonary artery and a mediastinal mass, where the hilum convergence sign shows the peripheral pulmonary arteries converging into the mass and not passing through it. It's converging at the mass, and this represents an enlarged pulmonary artery. So these images show severe enlargement of the pulmonary arteries. We can see on the axial CT and on the plain radiograph. These are of the same patient. Now, a hiatal hernia can also be probably seen as a mass on radiographs of the chest. A hiatal hernia is a protrusion of a portion of the stomach through the esophageal hiatus. The esophageal hiatus is an elliptical opening in the diaphragm and is just to the left of the midline. On radiography, you would see air or an air fluid level just above the diaphragm. So this frontal radiograph shows a retrocardiac lucency depicted by the arrows here, which was confirmed to be a moderate-sized hiatal hernia on the CT. Now, Morgagni hernia, still on the topic of hernias. Morgagni hernia is a diaphragmatic hernia through the foramen of Morgagni that occurs anteriorly, and it's where the two hemidiaphragms meet anteriorly, just behind the sternum. And a Morgagni hernia usually would contain omental fat. Sometimes bowel would also be in there. The contents of a Morgagni hernia typically fall to the right. So if you see an anterior mediastinal mass in contact with the diaphragm containing bowel gas, it is almost diagnostic of a Morgagni hernia. If bowel gas is absent, a key to diagnosis on CT is the detection of omental vessels in the mass that can be traced into the upper abdomen. So in these images, we see multiple air-filled structures seen in the lower chest here and to the right of the cardiac borders. And the lateral film actually reveals that the lesion is located just behind the sternum. This is the sternum. And there's communication between the intra-abdominal bowel and the lesion in the chest. This was a Morgagni hernia. Esophageal neoplasms may also be seen as visceral compartment mediastinal masses. A focal esophageal lesion is concerning for adenocarcinoma or squamous cell carcinoma. Esophageal carcinoma can present on radiography as abnormal convexity of the azygoesophageal recess, mediastinal widening, or even erythrotracheal mass. Benign mesenchymal esophageal tumors include fibrovascular polyps, leiomyomas, fibromas, or lipomas. A foregut duplication cyst can also present as a mass. Foregut duplication cysts include bronchogenic cysts or esophageal duplication cysts and even neuroenteric cysts. Although often they are low attenuation, you may have some internal heterogeneity due to hemorrhagic or proteinaceous components or even superinfection. Bronchogenic cysts can arise from any mediastinal compartment, but they most commonly arise near the carina and in the visceral compartment of the mediastinum. That's typically in the right paratracheal space, the subcarinal space, or the hilum. The lesion's thin walls may enhance or have intrinsic calcifications. Esophageal duplication cysts are just adjacent to the esophagus, right? And that's how you would differentiate the esophageal duplication cysts from the bronchogenic duplication cysts. They are all foregut duplication cysts. So these images actually show a subtle opacity overlying the right heart. If you look closely behind the right heart, there is the subtle opacity there. Has a different density than the cardiac shadow, and was shown to be a fluid attenuation lesion just adjacent the esophagus on CT. That is an esophageal duplication cyst here. Next is a paraganglioma. Now, cardiac or aortopulmonary paragangliomas can present as visceral compartment mediastinal masses that may arise from the phrenic nerve, the vagus nerve, and the recurrent laryngeal nerves. A paraganglioma is basically an extra-adrenal pheochromocytoma, and it's a highly vascular neuroendocrine tumor that originates from embryonic neural crest cells of the peripheral nervous system. It can be sympathetic or parasympathetic. A visceral compartment mediastinal paraganglioma tends to be parasympathetic in origin. Now, malignancy can occur, but it's just in about 10% of these extra-adrenal pheochromocytomas. And, pheochromocytomas can either be functioning or non-functioning. So in the same way, these paragangliomas can also be functioning or non-functioning. The CT appearance is of a hypervascular mass with feeding arteries. There may be internal heterogeneity that would represent necrosis. And on MRI, we would see a T1 intermediate, T2 hyperintense mass with homogeneous enhancement, indicating its avid blood supply. So this axial CT, contrast enhanced axial CT, shows a hypervascular mediastinal mass with central areas of necrosis here. And this is directly abutting the borders of the ascending and the descending thoracic aorta. It's just behind there. And that is consistent with a parasympathetic paraganglioma. I hope this has been useful. The next thing we'll talk about are paravertebral compartment mediastinal masses. Thank you very much for your attention. Give it a like, share, comment, subscribe if you have not subscribed yet, and I will see you in the next one.